All right, so we're into week 10 of the course, and this week we pick up with the healthcare system and with greater emphasis on the public system. So we'll look at Medicare, Medicaid, and then of course we have some substantial changes that have happened in the last few years as a result of the Affordable Care Act. And so we'll look at some of the major provisions that have gone into effect in the way of healthcare reform. And so here's just a quick outline of what I intend to cover in this two-part lecture. In the first part, I'll start with a quick introduction, laying out a case for why we needed healthcare reform, looking at some of the inadequacies that were existing in the system, and also some of the disparities in the system. And so we'll get into discussion about the existing U.S. healthcare system with, like I said, greater emphasis on the public system. We'll look at how Medicare operates, how Medicaid operates, and then we'll offer some discussion about the private healthcare system, some of the changes that have gone into effect. That'll be the first part of this lecture. And the second part of the lecture, we'll talk about one of the primary policy concerns is, of course, around the cost of care in the U.S. and the balancing of the cost and the quality. So costs, of course, keep escalating, but there's a concern about whether or not the quality of care being provided in the U.S. is keeping up with the costs. And so we'll take up that issue in the second part of this lecture. But first, just a quick introduction. So you'll note that we certainly have a new system in place. As a result of the Patient Protection Affordable Care Act of 2010, it was signed into law in March 23rd. And so this is a very complicated piece of legislation. When it was first signed into law, it was at 1,200 pages, but my understanding now is that with all the changes over the last 4 years, it's upwards of 8,000 pages is the legislation currently in place. And so it's certainly complex, it's certainly comprehensive. There's really no part of the healthcare system that remains unaffected. Certainly providers are affected, the doctors, the hospitals have been affected, consumers have certainly been affected. We have a lot more people who presumably are picking up health insurance coverage, and of course taxpayers have been affected as well, and mostly higher income folks have been affected, higher income tax-paying folks have been affected by these changes the most, I would argue. So why do we care? We take up this issue. Just a quick justification for why we study healthcare or healthcare policy in this class. So as future social workers, I assume that at some point in your career, you're going to come across a client that's going to need healthcare assistance with access to healthcare or issues of health insurance access. And so I think it's important for us to know at least a little bit about the background of the health insurance and the healthcare system in the U.S. And so I think I'm sort of preaching to the choir when I say that we need to learn a little bit about how the healthcare system works. So you can just think through why knowledge of healthcare policy and of health insurance in the U.S. would be important as future social workers. This is just laying out a rationale for why we needed healthcare policy reform, but certainly there are two main arguments that are put forth by policy analysts, and that's in the way of the inadequacy of the system prior to the Affordable Care Act and of disparities. And so if you look at the numbers, if you look at some of the background numbers in terms of the coverage, health insurance coverage, and I'm emphasizing here health insurance coverage. Health insurance coverage doesn't necessarily mean that you'll access the care that you need. So in the way of health insurance access, certainly we have huge gaps in the population in terms of who may or may not be covered. And so this is the most recent data that we have from 2013, the National Health Interview Survey. That's the survey that's used by the Center for Disease Control to estimate the percent who are uninsured. But this number seems to be getting better year by year. Every time I report this number in the lectures, we seem to be going down. So this is just a straightforward account of the number of people in the U.S. who reported being uninsured in 2012. So that number is at 14.8%. So when we had passed the Affordable Care Act, we were upwards of 16%. So we've made some improvements there. And you can see the number of people or the percent of people in the population without health insurance coverage for at least part of the year. And those who are persistently without health insurance coverage, those are all upwards of 10%. So just a simple case that we make for the inadequacy of even the current system, even with the Affordable Care Act and its changes. And I think you can certainly make a case for disparities in the system. And so we note that there are disparities across the board along various dimensions. So if we're looking at age, historically, the huge gap, at least in public health insurance coverage, was in terms of the working age population. So the working age folks are almost 3 times as likely to be without health insurance coverage relative to kids. And you'll notice that for seniors, we seem to be doing a pretty good job of making sure our elderly are with health insurance coverage. So only about 1 to 2% historically have 1 to 2% of the elderly are without health insurance coverage historically. So certainly age disparities, that's one dimension along which we see some disparities. And also in terms of race, education, and income as well, we see lots of disparities. So in terms of race or ethnicity, Hispanics, non-white Hispanics, much more likely to be without health insurance coverage. So almost 3 times as likely to be without health insurance coverage relative to non-Hispanic whites. And then, of course, in terms of income, those who are poor, those below the federal poverty guidelines, are 3 times as likely to be without health insurance coverage. And then, of course, education disparities as well. So those without a high school education are upwards of 3 times as likely to be without health insurance coverage relative to those with the high school education. So this is just some background information about some of the existing inadequacies and disparities in the current health insurance access in the system of access to health insurance coverage. So this is, I'm just showing here in terms of the numbers, what I just explained to you in plain language. So you can see some of the age disparities. We see that the uninsurance rates are highest. This is from 2012. The uninsurance rates seem to be highest among the working age population. So 19 to 64, these uninsurance rates are much higher. Kids were at 8.9% as of 2012. And like I said, for seniors, we seem to be doing a good job of protecting our seniors in terms of at least health insurance access, so 1.5%. And then I noted some of the race ethnicity disparities in access to health insurance. Hispanics were 3 times as likely to be without health insurance coverage relative to whites, we said. And notice that there seems to be a distinction here between foreign-born and native-born, 32% versus 13% in the way of health insurance coverage, or uninsurance, that is, foreign-born being much more likely to be without health insurance coverage relative to the native-born. So we were just looking at the uninsurance rates, and now we look at composition. So looking at those with and without health insurance coverage, what that composition looks like, we can see that most people hold private health insurance coverage in the U.S. So anyone who's charging the U.S. with being socialist, moving towards a socialist system, they're not looking at this number, because we see that most of our health insurance coverage is in fact in the private sector, so 63%, whether it's employment-based or someone goes out and they actually purchase their own health insurance coverage. Most health insurance coverage in the U.S. is in fact in the private sector. You can see the rates for our public health insurance system. Medicare, 15.7% of the U.S. population reports Medicare coverage and 16.4% for Medicaid. And then this is 15.4% uninsured rate. That's different from what I just reported before. This is from the census. So this 15.4% is reported from the census. That 14.8% uninsurance rate is from the National Health Interview Survey. So different estimates of the uninsured population in the U.S. All right, so looking at the existing U.S. Public health insurance system, we first look at Medicare. And so if we're going to be looking at Medicare and Medicaid, so the first thing to note, if someone asks you what the difference is between Medicare and Medicaid, we note that Medicare is a social insurance program, so all the things that we know about social insurance programs will apply to Medicare. And of course, Medicaid is a public assistance program, and so all of those characteristics that we know about public assistance programs apply to Medicaid as well. But first, in the way of Medicare, and you know that social insurance programs, you become eligible by way of contributions, and that's no different from our Medicare program. And so if you've made your required contributions, there are 3 different classes of persons, or 3 different pathways into Medicare eligibility. You can qualify based on age. And so if you're 65 and older, and you've made your required contributions, you qualify for Medicare Part A coverage. I'll talk about the different parts of Medicare in a second here, but you qualify for Medicare Part A. If you've been receiving Social Security disability benefits, so SSDI, if you've been receiving SSDI benefits for at least 2 years, you also become eligible for Medicare Part A coverage. And then a special category here, those with end-stage renal disease or kidney failure, in other words, may qualify regardless of age. So 3 different pathways into Medicare eligibility. You'll note the basic benefit structure for Medicare. Medicare is going to be broken up into 4 different parts. Medicare parts A through D. Part A is what we're paying into currently, right? So if you're making your FICA, if you're paying your FICA taxes and you don't really have a choice, and those things are getting taken out of your paychecks regularly, that's going towards financing hospital care for current Medicare beneficiaries. And so Part A, you'll note that it covers, like I was suggesting, hospital benefits, so your overnight hospital stays, some skilled nursing, and also hospice care, one sort of interesting area for social workers interested in maybe issues pertaining to the elderly. So it covers hospice care as well. And so you can see how the payment structure works. So you're going to have to pay a deductible. You don't have to pay premiums because you've paid your premiums over you've paid for the program over your lifetime, so there's no premium that a Medicare Part A beneficiary would have to make, but you do have to pay a deductible. So if you're hospitalized, just to give a sample here, if you're hospitalized, you're going to have to pay a deductible that's equivalent to about a 1-night stay in a hospital, which is about $1,100 as of 2010. And then at that point, Medicare Part A coverage will kick in. And so for the first 120 days of your hospital stay, Medicare will pay fully for those 120 days. And then after 120 days, there's a cost sharing between Medicare and the beneficiary. And so those are specific amounts. So there's this co-insurance system that Medicare Part A relies on. And then you have Part B. Part B, the main benefit that's offered, we're talking about doctor visits. Right, so outpatient care, doctor visits, Medicare Part B will cover these things. So your diagnostic testing, blood work, x-rays and such, Medicare Part B will pay for these things. But Medicare Part B is not automatic. Right? Part A, we know, is what you're paying into currently by the way of the FICA tax. But Medicare Part B, if you've retired and you've claimed Medicare Part A benefits, you have to pay extra. You have to pay extra premiums to qualify for Part B, and those premiums come out to about $100 a month. So as of 2010, the premium was $96.40. And so that'll pay for your eligibility for Part B benefits, your doctor visits and such. And then there's a deductible as well. So the deductible for 2010 was $155. You're going to pay the first $155 of your doctor visits and such. And then there's, of course, cost sharing. Medicare will pay for 80% of your doctor visits, and then you have to pay the remaining 20%. That's the co-insurance structure that's in place. So that's for Part B. And then for Part C is the Medigap plan. So any gaps that you have in coverage through Parts A and B, you can go on the Medicare website, and it functions like the health insurance exchanger. There's a bunch of private health insurance companies that offer their packages of health insurance plans that fill gaps in coverage that parts A and B may not cover. That's your Part C plan, and sometimes we call these your Medicare Advantage plans. And then, of course, we have Part D, which is the most recent addition to the Medicare program, and that's for prescription drug coverage. And this was part of the Medicare Modernization Act of 2006 that President Bush signed into law, which covers the cost for your prescription medications as a senior. And so I'm just showing here the cost sharing or the financing of Medicare Part D, your prescription drug benefits. So you're going to need to pay a separate premium for Medicare Part D. It's not automatic like Part A. You have to pay additional premiums for Part B, for Parts B, C, and D. And so once you've made those your regular premium payments, there's $310 of your first $310 of prescription drug costs you're going to have to pay out of pocket. So that works like a deductible. And then if you have prescription drug costs, annual drug costs between $311 to $2,830, Medicare will pick up 75% of that amount. You have to pay 25%. And then there's this huge gap. There's this huge gap in coverage from $2,830 to $4,550 in the way of your annual prescription drug costs. You have to pay out of pocket for that level of expense. And so we call that the donut hole. You may have heard reference to the donut hole in the Medicare Part D program. And that's something that the Affordable Care Act addresses. We're going to close that donut hole gradually, such that it will not remain by the year 2017. And then, of course, Medicare covers 95% of catastrophic costs So anything in excess of $4,550 in the way of prescription drug expenses on an annual basis, Medicare Part D will foot that bill. And so that's the basic cost-sharing arrangement for the Part D program. This is just a note on some of the changes that the Affordable Care Act implemented. So when the Affordable Care Act was first passed in 2010, there was a concern about those who might retire a little bit early. So let's say you're a person who's approaching retirement age, you're maybe age 62, and you can claim Social Security retirement benefits as early as age 62. But if you retire, you may not be covered under your employment-based plan any longer, and so you might have a gap between age 62 and 65 in the way of health insurance coverage. And so initially we had, as a part of the Medicare changes, we had initially sought to insure those persons who may retire early. There was a temporary reinsurance program that was put into place. That was one of the major changes that became part of the Affordable Care Act. And then another major change with the Affordable Care Act was an increase in the FICA tax. So we noted that the FICA tax pays for your Part A benefits. So we increased that tax for higher income workers. As of 2013, if you were an individual making more than $250,000, you would have to pay an extra 1%. So while that tax was basically a flat or a proportional tax, it didn't matter what level of income you had, 1.45% you would have had to pay that tax. As of 2013, for higher income workers, you have to pay an additional 1%, and that's to finance lots of these changes that were implemented as part of the Affordable Care Act. All right, so we're looking at Medicaid, which is sort of the twin to the Medicare program. This is, of course, we know it's a public assistance program. So all the things we know about public assistance programs will apply here in the way of Medicaid. So note the historical cost-sharing arrangement that Medicaid relies on in terms of its financing. So the federal government will share the cost of administering the state Medicaid program. It's primarily run by the state, but the federal government will support anywhere between 50 to 80% of costs, and that depends on state wealth. So typically, the wealthier the state, and that's measured in the way of income per capita, how much people make typically in your state. Where the per capita income is higher, the federal contribution will typically be lower, more towards the 50% range. And then, of course, vice versa. Where the per capita income is lower, the federal contribution is higher. That's the typical formula that's used to finance Medicaid benefits. And so Medicaid, as we know, has been expanded to cover the working age population, the group that has been historically left out of Medicaid coverage. But of course, states have the option to expand Medicaid coverage. They don't have to necessarily, they have the option to do it. And the federal government will support 100% of the cost of any of those expansions. So those are some of the major changes. I want to point out here, just in terms of the composition of Medicaid enrollees. So one thing to note here, you'll notice that the elderly make up 25% of Medicaid enrollees, but they count for 75, it's not shown here, they actually count for 75% of costs. So you can see that the elderly and persons with disabilities, for that matter, are making up a substantial portion of costs. Their services are much more expensive, right? You can see that their services are much more expensive. I'm sorry, I pointed to a wrong number. So 10% seniors, 17% in the way of persons with disabilities. That's 27% of the composition, but you can see that the costs are much higher. For a person with disabilities, $10,000 or $12,000 per person relative to kids and persons and low-income adults. And so that's one of the primary issues that we have to grapple with in terms of healthcare reform today. This is just showing some of the basic services that are offered. So the states must offer the federally mandated services. So things like overnight hospital stays or doctor visits, pregnancy services must be covered under your state Medicaid plan, and of course, long-term care must be covered. So nursing home stays for people over age 21, that must be covered under the state Medicaid plan. And then there's some optional services that states may pick and choose from. So things like dental care, eyeglass care, and prescription benefits. States have the option of whether or not they offer these services. And so I noted some of the substantial changes in Medicaid since the Affordable Care Act, or since passage of that legislation. So initially we expanded Medicaid coverage to all working age folks. So anyone between age 19 and 64 who were previously uninsured, we offered Medicaid coverage. But of course now states have the option. States can choose whether or not they expand coverage to the working age population. And so there was also an issue of fragmentation. So because Medicaid is administered at the state level, many states were offering different packages and different eligibility requirements. So we tried to standardize the way we operate Medicaid across all the different states as a result of the Affordable Care Act. So just a quick note on a program called CHIP, or the Children's Health Insurance Program. This is not an entitlement program. This is not like Medicare and Medicaid. It's a supplemental program. So if states have some leftover money, they can operate this supplemental program for kids. And basically the way this program operates is where the state may have a cutoff in terms of those who might be eligible for Medicaid coverage. A state may offer Medicaid coverage for kids up to 133% of the federal poverty line. And then the states, if they have some money left over, they may offer the Children's Health Insurance Program for up to 200% for kids up to 200% of poverty. That's a typical arrangement that's used in the way of the CHIP program. So it's not an entitlement. So states can have the option of whether or not they're going to offer this program. All right, just a quick note. We just covered the public health insurance system very quickly, and so now we look at the private insurance system. And so you'll note that most recently we have this health insurance marketplace. So those without health insurance coverage, they may not have, so people who don't have private employment-based coverage or public coverage in the way of Medicare and Medicaid, they have to go out. As of 2014, you have to go out and get covered. And so you'll go to the Health Insurance Exchange, and it's basically just a website. And it may differ from state to state. For Illinois, that website is getcoveredillinois.com. And so if you go to that website, you can find a private health insurance plan that meets your needs. And so you'll note that everyone must be covered. That's what the new law says. And if you're not covered, there's a penalty. It's called individual responsibility payment. And so that penalty, if you're not covered if you don't enroll by the end of this enrollment period, that's going to end up in March. We're talking by the end of March 31st, 2014. If you're not covered, there's an individual responsibility payment, and that's for $95 per adult. We note what the penalty amount is, or 1% of household income, whichever is greater. And so a note here that that penalty is going to go up substantially after this first year. In 2015, if you're not covered, if you don't have a private employment-based plan or Medicare or Medicaid coverage, you're going to need to purchase a private plan. If you don't, that penalty goes up to $325 by 2015, and then you can see that it goes up to $695 by 2016, or 2.5% of your household income, whichever is greater. So that's a pretty steep penalty that the federal government will impose on you if you don't get coverage. So that's one of the more recent changes to our healthcare system. Of course, you've probably heard about this. And then this is just some quick information about the types of plans that are offered. For more information about this, you can also go to healthcare.gov, and that's the federal health insurance marketplace system. So for Illinois, specifically, you go to Get Covered Illinois, and for the federal system, you can go to healthcare.gov to get more information about how the marketplace works. But basically, you have a choice of between 5 different plans, ranging from bronze plans all the way up to platinum coverage and catastrophic coverage. It's your choice of a plan basically depends on how you want to balance your monthly premiums, your regular payments, and out-of-pocket expenses. So if you get a bronze plan, for example, right, it may be cheaper for you, and you may be paying less in the way of monthly premiums. But if you were to get sick and you need some type of coverage, some health care in the way of doctor visits or overnight hospital stays, for example, you're going to end up paying more out of pocket when that time comes. Or maybe you get a more expensive plan, like a platinum plan or a catastrophic, not a catastrophic plan, but certainly a platinum plan or gold plan. You're going to pay much more in the way of monthly premiums, right? Out of pocket, you'll pay much more regularly. But then once you need actual care in the way of hospital stay or doctor visits, you'll end up paying less at that point. So it's a balancing of how you want to distribute your premiums and your co-pays. And so the federal government is reporting that we're going to minimize your out-of-pocket expenses. So this is the maximum that you would have to pay as of 2014 out-of-pocket, $6,350. for an individual plan, and then for family plans, there's a different capped amount. And then, of course, the different factors that go into the pricing of these plans, where you live matters, whether you smoke matters. There's lots of different things that go into it, into the formula. Your age, your family situation will all determine the price of the plan. Of course, the type of plan matters as well. Just a quick note here about on the business side. So businesses, if you're a large employer, if you have 50 or more employees as a business, and you have, this is pertaining to full-time workers, those who work 30 or more hours, you as a business must offer coverage as of, that doesn't kick in until 2015. The employer mandate doesn't kick in until next year. And so you can see that there's some incentives also for small businesses in the way of tax credits. So tax credits that cover up to 50% of the cost of the premiums for businesses. Otherwise, there's a penalty for large employers. If you don't offer health insurance coverage as a large employer, there's going to be an employer mandate or a penalty that's assessed against businesses as well. So it's not just individuals that have to pay into the system, but the businesses will have to pay as well. And then finally, in this section, I just want to offer a note about the tax treatment, about the federal tax code. The tax code and how it operates in the way of assessing, in the way of thinking about the tax liability for low-income workers versus high-income workers. So note that there is no tax necessarily. There is no tax on your private health insurance plan. And so the fact that your private health insurance plan goes without tax liability, that works much more favorably for the higher income worker relative to the low income worker. So if you think about the counterfactual situation, so if the federal government had imposed some sort of tax on your health insurance benefits, so your private employment-based health insurance benefits, if those things were taxed, you can imagine that that would be much less favorable for the higher income worker who's subject to higher marginal tax rates. But since those things go without tax liability, it's much more favorable for that worker who's subject to those higher marginal tax rates. So just a quick note that the tax code favors the private system certainly and higher income workers. So it's we have a regressive tax system certainly, right? And even those penalties, that $95 is going to be a much larger percentage of a lower income worker than the higher income worker. So certainly a much more regressive in nature, in both realms there. So we'll wrap up the first part of this lecture, and we'll look at a basic policy issue, this tension between cost and quality, in the next part of this lecture.